Okay, this video is going to cover some of the techniques that are used for chest imaging. So again, hopefully some of this is a review, but remember that the posterior anterior view or the PA view is the standard. And so this is usually achieved with a patient standing erect in front of a scanner. And then an AP view is usually done on a supine patient. So again, that's going to be where the x-rays are projected through the anterior chest wall and they'll exit through the posterior wall directly onto the detector from there. Left lateral view, so typically if we do a lateral view, it's going to be a left lateral view. There are rare occasions where it'll be a right lateral view, but most of the time it's going to be a left lateral view. And again, this is going to be where the detector plate is up against the left side of the chest. So the x-ray beam is projecting through the right side of the body and then going through and exiting on the left side of the body onto the detector plate. And then also a lateral decubitus technique can also be done. That's where the patient is laying on their side, usually in a bed, and the x-ray will project through the patient, very similar to an AP view. So here's what it looks like on a PA view. So you can see how the patient is standing up against the detector, and then these arrows represent the direction of the x-ray beam going through the chest into the detector right there. And usually when we do this type of standard PA chest x-ray, we have the patient take a full deep breath in and then shoot the x-ray, and that helps us to be able to better appreciate the structures of the thorax. But realize inspiratory versus an expiratory chest x-ray is going to look very different, with the structure significantly elevated or in a more superior position in a patient that has exhaled, as opposed to an inspiratory volume. So here we can see a typical PA view. So again, you start with your skeletal overview. You can see a number of posterior ribs. You can also see some of the anterior ribs kind of arching around inferiorly over here laterally. Usually you can see around 6 anterior ribs and about 8 to 10 posterior ribs, which again you can see are in a more horizontal position. If they're not perfectly horizontal like in this image, it's probably because the beam and the detector weren't perfectly aligned, or the patient wasn't perfectly upright in between the two, between the beam and the detector. Here you can see just another thing to keep in mind is, especially in females, you can see the breast will cause a shadow effect, totally normal, so don't think that that's an abnormal chest x-ray. You just want to pay attention to that. Keep in mind you'll also be able to see the nipple shadow. Oftentimes you don't see it well in this image, but we'll see one later on where you can see that quite well. And so here's a list then of a number of structures within the chest. The few bones that we outlined, but a lot of the soft tissue, key features of a chest x-ray. And so we'll walk through each one of these to give you a sense of where you want to be looking. So first off, you can see the arch of the aorta is pointed out here by that yellow arrow. Then we have what's called the azygoesophageal line. So this is going to be usually the right border of the esophagus, and that's lining up with the azygos vein or azygos vein as that is ascending up towards the SVC. Then we can see the left lateral wall of the descending aorta. So again, you can see the arch of the aorta here, and then the left lateral wall of the descending aorta as it descends down towards the abdomen. We have the AP window or aortopulmonary window, and so I'll kind of go back and forth just so you can appreciate that. So again, that's going to be formed by the arch of the aorta and the left pulmonary artery. So we'll talk a little bit more about that later on. Then you can see the trachea. So notice how you can kind of see this darker outline here, and then you can see that continuing down into the main stem bronchus down here. So just keep in mind that because air is radiolucent, you're going to have a more black appearance. Just like you can see the air over here appears black on the image. Same thing here where the trachea is. You're going to see sort of a shadow effect from that. And that's the same reason the lungs have a dark appearance to them, because they're primarily filled with air. So again, the trachea, and then the left and right main stem bronchi. Remember, the right main stem or primary bronchus is going to be more vertical. The left main stem is going to be a little bit more horizontal. And then over here we can see the border of the left border of the heart represents the left ventricle. Over here you can see the right atrium. Again, notice how that's far more radiolucent than much of the rest of the heart. That's because there's not a lot of muscle tissue, as you know, in the right atrium. Oops. And so then we can see some of the bony structures here. So the medial ends of the clavicles. So you can see again the clavicles coming across, and then here's the heads of the clavicles as they're articulating with the manubrium of the sternum. We can see the spinous processes of the thoracic vertebrae. So again, you can see these spinous processes right here, and you can also appreciate the transverse processes coming out and articulating. You can see it really best up here at T1. So this is going to be the spinous process of T1. This is the transverse process of T1, and then you can see the first rib as it's arching around off of that. Again, you can see that well over here on the patient's right-hand side as well. So remember, this is patient right, this is patient left. And then we have the medial border of the scapula, so you can see that quite well on either side of this patient. So again, that's all going to be representing the medial border of the scapula right there. So keep that in mind, that you can see that on chest x-rays quite well. And then finally, the right and left hemidiaphragms. So again, remember that your right hemidiaphragm is going to be located higher than, or more superiorly than, the left, and that's because the liver is sitting right here and pushing that up. And usually right underneath the left hemidiaphragm, you should see a gas bubble, which is representing the stomach. So that's a good way to confirm that that's what you're looking at, is the left hemidiaphragm. Is look for that gas bubble in the stomach. So again, going back to the AP view, remember this is usually done in a supine patient. So you can see the x-ray beam sending x-rays through the patient anterior to posteriorly, and then hitting the detector here below the patient. And one of the key points to remember with an AP x-ray is that it's going to magnify the heart and the structures of the superior mediastinum. So it's not the standard for trying to measure or determine whether a patient has cardiomegaly. So here's an AP view, so hopefully you can appreciate the heart appears a little bit larger in this image relative to a standard PA view. And so we can see that outlined here a little bit better, where again, you can see this is a PA versus the AP view, and so you can see on the same patient how much larger the heart appears here on the right with the AP view. And so generally when we estimate heart size, we use a PA view, and in this case, we normally say that the cardiothoracic ratio should not exceed 50%. And so again, you can measure all the way across the thorax, and then measure the length of the heart, and the ratio between the two should not be greater than 50% in terms of the heart relative to the thorax. Another way to do it too is to find the midline of the spine, and then estimate in one hemithorax, so one side of the thorax, and make sure that the heart doesn't extend past about the midway point. So that's going to be 50% of either hemithorax. If it does, as it does on this side, in that case, it could indicate cardiomegaly, but because this is an AP view, it's not a reliable measurement. But here you can see this is one where the cardiothoracic ratio is 65%, and so very clearly, if you look at one half of the hemithorax, you can clearly see that the heart is well past the midway point there, and so this definitely indicates cardiomegaly. And again, you're typically going to be looking for that more so on the left-hand side, but you can also see on the right here that obviously that is very close to the midpoint and further over than what you typically expect the right border of the heart to be. So that's cardiomegaly. So here we have the left lateral view. So again, with the left lateral view, remember that the x-ray beams are entering the right side, patient's right side, and exiting through the left to the detector. And so this is going to diminish some of the effects of magnification on the heart, because again, the heart's on the left, so the beams are contacting the heart later on in their course, and so as a result, it doesn't really magnify the heart as much as it does with the right lateral view. And then keep in mind that the left hemidiaphragm is usually going to appear lower than the right on a left lateral view. And then the anterior left hemidiaphragm is silhouetted out by the heart, so you're not going to be able to see it along its entire course, whereas the right hemidiaphragm you will be able to see along its entire course. So if we look at what that looks like, here we can see the left hemidiaphragm here versus the right hemidiaphragm up top there. So again, notice how the right hemidiaphragm, you can see how it's extending all the way to the anterior chest wall, whereas if you look at the left, it eventually sort of disappears behind it's silhouetted again by the presence of the heart. And then lateral decubitus, again, this is typically done on a patient that's laying down, and so this can be really, really useful for trying to appreciate or localize the volume, or analyze rather the volume of a pleural effusion. So just as a reminder, a pleural pleural effusion is a collection of fluid in the pleural cavity. So here we have an example of a right pleural effusion. So again, this is a patient in a decubitus, lateral decubitus position, and so you can see here the fluid in the lung on the right side of the lung. So once again, this is a right pleural effusion in this case.